Introducing myself, I'm Dr. Dinesh, one of the mentor of Team StudyMEDICs. In this session, we are going to talk about maternal medicine. Maternal medicine is being one of the very important MRCOG Part 2 module, rather than it has been considered as one of the vast module which includes many more topics. But believe me guys, nothing is impossible because the word impossible itself says that I am possible. And how this maternal medicine syllabus compilation is possible, because understand one thing, in your medical school you have already covered many more the topics into the internal medicines, and those topics has certain obstetric implication, and that becomes a part of maternal medicines. So nothing to worry, you already have an ample amount of idea about the medical conditions, only the obstetric implications that need to be applied. But for that purpose, having the basic understanding about obstetrics will definitely help you for you to compile maternal medicine in one go. So let's start this session with the understanding about anemia. We know it is one of the common conditions that we do face into the antenatal period. So what is the definition of anemia as per the WHO? In a non-pregnant patient, if the hemoglobin concentration is less than 12 gram per dl, or in pregnant patient in the first trimester if it is less than 11, in second and third trimester if it is less than 10.5, and in postpartum if it is less than 10, that will be considered as a case of anemia, that is hemoglobin deficiency. The most common cause of anemia is iron deficiency anemia. Going ahead, let's talk about certain hemoglobinopathies which are very important for your MRCOG part 2, which include the thalassemia, sickle cell disease. In sickle cell disease, the vaccination schedules is very frequently been asked for your MRCOG part 2 exam. Talking about H influenza, a single dose has to be considered if it is not taken before during the course of pregnancy. The conjugated meningococcal vaccine as a single dose if it is not taken before. Pneumococcal vaccines to be considered for every 5 yearly. Hepatitis B vaccination should be taken preconceptionally, and it depends upon what status patient carries. The flu and swine flu vaccines will be considered on annual basis. Let's come to the question. A 29-year-old para 2 living to beta thalassemia major patient is on the iron chelating agent, that is desferrioxamine, for iron chelation therapy. Mother is worried about its effect on baby while she is continuing the breastfeeding. The option A, whether it is safe in breastfeeding, mother needs assurance only. Stop breastfeeding while it is on desferrioxamine. The breastfeeds after 2 hours of taking the desferrioxamine. She should withhold the desferrioxamine, and breastfeeding should not be done for 14 days. Among these 5, what is the best answer in your mind? The answer is yes, it is safe in breastfeeding mother, only she requires the assurance. The women with thalassemia are often on a range of drugs, some of which may be teratogenic, that might have the hampering effect on baby. Animal studies with desferrioxamine did not show any teratogenicity. However, there is only limited safety data on its use in the pregnancy. Talking about deferrioxamine and deferriprone should be discontinued 3 months before the conception, and woman is converted to the desferrioxamine iron chelation therapy. Talking about desferrioxamine, it has a shorter half-life, safe for infusion during the ovulation induction therapy. It is to be avoided in the first trimester as owing to the lack of safety data. It is safely given after 20 weeks of gestation at a low dose, and it secretes in a minimal quantity in the breast milk, and no adverse effect has been noted so far, and that's the reason it can give the assurance to the patient that they can continue with this therapy. Whenever there is a requirement of the iron chelation therapy, what are the criteria? Whenever the myocardial iron load with a T2 weighted scan is less than 10 millisecond, the liver iron more than 15 milligram dry weight as measured by MRI, and those are the women at a highest risk of cardiac decompensation should commence on the low dose subcutaneous desferrioxamine, which includes the 20 milligram per kg per day on minimum of 4 to 5 days a week under the joint hematology and cardiology guidance from 20 to 24 weeks of gestation. It's very important because of the repeated transfusion, these patients are at risk of having the iron overload. Talking about thalassemia is a medical condition which has an autosomal recessive pattern. It means that 1 in 4 is getting affected. Preconceptually, couple of advice that requirement of the chelation therapy to reduce the iron burden. Screen for end organ damage for iron concentration. Screen for glucose by means of serum fructosamine at least 3 months prior. Why not HbA1c? Because repeated transfusion will have the low measurement of the HbA1c, and that's the reason serum fructosamine will be considered as a preferred choice over here. Vaccination, hepatitis B in a patient who have transfusion and hepatitis negative status. Splenectomy for a patient, and penicillin prophylaxis is recommended. Pneumococcal and influenza vaccine will be required, and a high dose of folic acid, that is 5 milligram, is required. In MRCOG Part 2 compilation syllabus, you should understand at what medical condition you will be considering the folic acid of 5 milligram. Please note the conditions and mention it to the chat box. That will help other students. What could be the risk? Risk to the mother in terms of cardiomyopathy. At 28 weeks, the cardiac assessment of mother is a requirement for that purpose. There could be a possibility of endocrine abnormalities by means of diabetes mellitus, hypothyroidism, hypoparathyroidism, and baby might have the likely chance of having the IUGR. This is how the trait is being passed in autosomal recessive condition. Understand, if the father is carrier and the mother is also carrier, then there is a 25% chances that child may be normal, 50% chances that child may be carrier, and 25% chances that child may be affected with the condition. So certain preconceptional screening will be required over here in terms of organ damage. For example, diabetes mellitus by means of serum fructosamine concentration. For thyroid, needed thyroid function evaluation. For a heart, it required the ECG or 2D echo requirement and T2 weighted cardiac MRI. For the bone density scan to document the pre-existing osteoporosis and serum vitamin D concentration so that we can optimize. Because of the repeated transfusion, the red cell autoantibodies can form, and that's the reason ABO and full blood group genotype and antibody titer will be required. Iron chelator, the chelators like deferoxyrox and defibribone, ideally discontinued 3 months prior to the conception. In liver, because of the iron overload, the Ferry scan on liver, which is on T2 weighted scan, ideally the liver iron should be less than 7 milligram per kg dry weight. Liver and gallbladder and spleen, if present, then ultrasound is required in order to detect the cholelithiasis and the evidence of liver cirrhosis due to the iron overload or transfusion related to the viral hepatitis. Hepatitis C status should be determined because this patient will be on recurrent transfusion, and that the hepatitis C can be transmitted. In terms of preconceptional care, the genetic screening is required. Understand, if the partner is affected with the condition, IVF or ICSI with the help of pre-implantation genetic diagnosis can be offered to the patient. If the partner is carrier, in that case, the genetic counseling will be required. And if partner is unavailable or his status is not aware, then yes, prenatal testing will be required. And that's the reason the egg and sperm donor should be screened for the hemoglobinopathy. There are certain conditions which requires the counseling where mother is affected with the thalassemia. What are these conditions? If the partner is affected or a carrier of beta thalassemia, hemoglobinopathy, which include S, E, delta beta thalassemia, lepro, HBO, ARUP, constant spring. So in that category, the risk of serious hemoglobinopathy is applies to all. And that's the reason the counseling will be required. Talking about hemoglobinopathy, which include the C, the risk of mild to moderate disorder will be there in the child. In this quantum, the thromboprophylaxis plays very important role. If spleen is absent or spleen is removed by means of splenectomy or platelet count which is more than 6 lakh, in that condition, the low dose of aspirin will be required. But if both the conditions are present together, for example, splenectomy along with the platelet count which is more than 6, then definitely low dose of aspirin along with low molecular weight heparin will be required. Prophylactic low molecular weight heparin during the antenatal hospital admissions will be always advisable. Whenever there is a normal vaginal delivery, the low molecular weight heparin will be continued for 7 days after the delivery. And in terms of C-section, the low molecular weight heparin will be continued for next 6 weeks. A very important genetically linked condition called as hemophilia. So hemophilia is a very important guideline that one should be reading in detail. Hemophilia A is because of the deficiency of factor 8. Hemophilia B is because of the factor deficiency 9. 50% of the neonatal males with severe hemophilia have no family history. 90% of the mother of such a babies are being carrier. The factor 8 as to vulnerability factor level, which is less than zero point 0.7, is suggestive of the carriership. And the inheritance pattern of hemophilia is X-linked. These are the one-liner which is very frequently asked in your exam. In terms of severity, it will be graded as severe, moderate, and mild. Let's understand what is the severe. Severe is that factor 8 as to factor 9 level is less than 0.01 international unit per ml. In moderate, it is 0.01 to 0.05, and in mild, it varies between the 0.06 to zero point 0.4 international unit per ml. Talking about severe hemophilia, what are the clinical features that you could see? That is intracranial hemorrhages, the spontaneous bleeding to the muscles and joints in the dependent part could be there. The mild to moderate cases, the only for trauma and invasive procedure, there is a concern. 10 to 14% treated patients develop antibodies to the clotting factor. So it's very important to know about this condition in detail. A very important TOG article about the renal transplant or organ transplant is there, and please go through the TOG article because it has many more informations and the upcoming questions has already been asked in your exams prior to that. So talking about post-renal transplant, there are the couple of clinical scenarios that we'll discuss now. Mrs. Susie is 8 weeks and she is on tacrolimus. What special advice will be considering as she is on tacrolimus? Tacrolimus is something the pre-dose serum level no less than monthly monitoring will be required, and there is a requirement of GDM screening. Mrs. Rumi, second question, 20 weeks on cyclosporine and has a recurrent otitis media, and she has been advised to take a calithromycin antibiotic. What advice will be considered over here? Calithromycin should be avoided. The clinician should be aware that both cyclosporine and tacrolimus are metabolized by cytochrome P450, and that drug that inhibits the cytochrome isoenzymes, including the erythromycin and calithromycin, can lead to the calcineurin inhibitor toxicity. In that context, the alternative medication should be used wherever it is possible. Talking about post-renal transplant, another scenario where Miss Rami, 28 weeks, the current blood pressure is 160 by 110 millimeters of mercury, and her protein creatinine ratio is 35 milligram per millimole, and low placental growth factors has been seen. So what is your conclusion? The development of new proteinuria after 20 weeks of gestation is diagnostically useful in a woman who are known to have no proteinuria in early pregnancy. Alternatively, an increase in blood pressure to more than 160 by 110 millimeters of mercury, or an increase in the treatment to maintain the blood pressure at less than 160 by 110 millimeters of mercury, or 100% increase in the proteinuria from the level in early pregnancy to the protein creatinine ratio of greater than 30 milligram per millimole should be considered suggestive of superimposed preeclampsia. There is a new evidence that the placental growth factor is not affected by renal function, and low level are associated with a superimposed preeclampsia even in the context of renal dysfunction. So it is very important information that this TOG article provides. Please read the TOG article if you have not completed so far. A fourth question, Miss Rosie, 24 weeks. Check up now, and her BMI is 30 kilogram per meter square. Her protein creatinine ratio is 308 milligram per millimole, and her blood pressure is 140 by 80 millimeters of mercury, and she is on antihypertensive. What advice you gonna give? We need to start this patient on low molecular weight heparin as a prophylaxis, and here it has been advised that whenever urine protein as to creatinine ratio is more than 300 milligram per millimole, or the albumin creatinine ratio is greater than 180 milligram per millimole, in that context, it is more likely that there is a formation of thrombus or blood clotting will be get affecting, and that's the reason this patient required a thromboprophylaxis. A very important one more talk article about diabetes ketoacidosis. Understand diabetic ketoacidosis is a very important condition rather than it's a medical emergency at the point. So, how to diagnose the diabetic ketoacidosis? As per the Joint British Diabetic Society Inpatient Care Group Guidelines states the following diagnostic criteria, which include blood ketone level more than or equal to 3 millimole or urine ketone level more than 2 plus, the blood glucose level more than 11 millimole per liter, or a known case of diabetes mellitus, bicarbonate level less than 15 millimole per liter, or the venous pH which is less than 7.3. It is the diagnostic criteria for diabetic ketoacidosis. In the management of diabetic ketoacidosis, as I said, it is a medical emergency. The multidisciplinary approach will be considered where the IV fluid therapy, the intravenous insulin therapy, electrolyte correction, evaluation of the need of bicarb administration, the identification and the treatment of any precipitating factor which leads to the diabetic ketoacidosis, and monitoring of the maternal and fetal responses will be required. In terms of IV fluid, understand very well that the fluid of choice will be 0.9% normal saline. Whenever there is a potassium replacement, always replacement and the insulin therapy is required, it is always on the basis of potassium. If the potassium level is less than 3.3, then we need to give the potassium. Don't give IV insulin because there will be potassium dysregulation. If it is between 3.3 to 5.5, then we need to give the potassium along with the IV insulin. And if it is more than 5.5, definitely the level will be on higher side, no need of potassium, and only the requirement of insulin will be considered. Identify the cause, get certain investigation done like CBC, urine analysis and culture in order to rule out what could be the reason of having this trace leading to the diabetes ketoacidosis. Monitoring of the patients will be required. Fetal monitoring is mandatory. Now, you need to understand what are the metabolic targets and what are the resolution criteria. Talking about metabolic targets, the decrease of blood ketone by 0.5 millimole per liter per hour, improvement of venous bicarbonate by 3 millimole per liter per hour, that is 3 milliequivalent per liter per hour, decrease of capillary glucose by 3 millimole per liter per hour, which is nothing but a 54 milligram per dl per hour. This is something considered as diagnostic metabolic targets. Talking about resolution criteria, whenever the ketone level are less than 0.6 millimole per liter, pH which is more than 7.3 units, the bicarbs which is more than 12 millipole per liter, and anion cap which is equal to or less than 12, then this has been considered as the resolution criteria. Coming to the question, woman with type 1 diabetes presented with a suspected diabetic ketoacidosis following a protracted period of vomiting. Initial investigation gives the following result where the bicarb is 13 millimole, the serum glucose is 18 millimole per liter. So what would be the threshold value for serum ketone to confirm the diagnosis of DKA? Wonderful. The answer is 3 millimole per liter. This is what the criteria which has been given by the Joint British Diabetes Society Inpatient Care Group guidelines. So please remember this criteria very well. The woman with type 1 diabetes present at 11 weeks of gestation with diabetic ketoacidosis following several days of vomiting. What is the intravenous fluid of choice for the initial fluid replacement? Start thinking. I'm really happy to know your answer. That's yes, it's normal saline. As we have already discussed that it is an isotonic saline of 0.9%. Coming to a very important condition, pulmonary embolism. Whenever there is a suspected pulmonary embolism, in that case, you need to do a quick clinical assessment, perform X-ray and ECG, get done the blood test like full blood count, urea electrolyte and LFT, and start on low molecular weight heparin unless and until it is contraindicated, because it is a very quick emergency situation. If you noted that there are signs and symptoms of DVT, for example calf tenderness, then yes, perform the compression duplex ultrasound. And if your ultrasound findings are positive, then continue the therapeutic dose of low molecular weight heparin where you are very confirmed with your diagnosis now. But there are no signs and symptoms of DVT, or even the duplex compression ultrasound is normal, then what you want to do? Then you need to perform a chest X-ray. If chest X-ray is normal, then you need to perform the ventilation perfusion scan. If it is abnormal, then you need to perform the CTPA, that is pulmonary angiography, and that will help you to confirm about pulmonary embolism. And yes, if it has been confirmed, then you need to continue with the therapeutic dose of low molecular weight heparin. But still it is not confirmed, then it depends on the clinical suspicion of pulmonary embolism. If it is low, then discontinue the low molecular weight heparin and consider the alternative diagnosis for the same. But if your clinician feels that the suspicion is on a higher side, then consider the alternative and repeat testing, but you need to continue with the low molecular dose heparin. This chart is very important for your exam purpose, because whenever you are suspecting pulmonary embolism, you should be very quick in management of patient. Then coming to the diagnosis, confirmation, or in that context you need to think about whether DVT is there. If DVT is not there, then what could be the cascade based on chest x-ray, based on chest x-ray finding, if it is normal, abnormal, and the further modalities, so that you should be firm with your diagnosis and further course of treatment. I hope this chart is well understood, and again revise this chart before your exams. The chest x-ray is normal in the full 50% cases of the pulmonary embolism. There are certain findings in ECG, that is T-wave inversion seen in 21%, S1Q2T3 pattern in 15%, right bundle branch block seen in 18% of the cases. And very important differential over here is ischemic heart disease, and that's the reason we are getting the ECG done over here. Let's come to a question. A pregnant lady complaining about severe chest pain, X-ray is abnormal, and having a history of calf swelling, which is tender since last 3 days, and the long-standing job with a varicose vein, and she is asked for the next investigations. So here you are having a suspicion about the DVT, and how we'll confirm by means of duplex ultrasound. Let's have a few more quick questions. There is a suspicion of pulmonary embolism, calf tenderness is present. There is suspicion of pulmonary embolism, but there is no history of DVT, even the chest x-ray is normal. There is suspicion of pulmonary embolism, no history of DVT, and chest x-ray is abnormal. What are you gonna do? This is as per our flow chart. Yes, whenever there is a suspicion of DVT, do a duplex ultrasound. If there is no DVT but chest x-ray is normal, do a ventilation perfusion scan where you require a more intensified radiation exposure. Once you know that the chest x-ray is abnormal, you are very closer to your diagnosis. A least radiation exposure technology like CTPA will be required over there. Going ahead with this chart, understand again one very important thing. The first thing that you'll be doing the chest x-ray and ECG, because you need to differentiate between the ischemic heart disease or any other lung pathologies. Get full blood count, urea electrolyte, and LFT done. You understand that in Green Top guideline, the thromboembolism prevention and treatment options has already been discussed detail in two separate versions, 37A and B version of guidelines. This guideline will help you in clearing the questions about this VTE, and understand in the annexure there are the charts which are mentioned, very important chart which help you in understanding that what duration of low molecular weight heparin to be continued. You need to understanding the scoring system very well. So just to know one very important thing, look into the BMI into the question. If the BMI is 30, the score 30 and above, it will be considered as score 1. Whenever BMI is 40 and above, then it will be scored as 2. If the total score is more than or equal to 4 antenatally, then you need to consider the thromboprophylaxis from the first trimester itself. If the score is 3 antenatally, then you need to consider from 28 weeks onward. If the score is more than or equal to 2 postnatally, then you need to consider the thromboprophylaxis for at least 10 days. If patient is admitted into the hospital antenatally, then you need to consider for thromboprophylaxis. And whenever there is a prolonged admission, which is more than 3 or equal to 3 days, readmission to the hospital within the period, you need to consider for thromboprophylaxis. Understand very important line. A patient who is on a thromboprophylactic agent antenatally, they will be required thromboprophylaxis for next 6 weeks after the delivery. So here is the scoring system that help you understand the parity, which is very important, that 3 or more than 3 will be considered as a score 1. Obesity we have already discussed, BMI more than 30 or is considered as 1, BMI more than or equal to 40 considered as 2. This is the one thing that I wanted to highlight over here. Elective C-section 1 and cesarean section in labor, whenever it has been mentioned that patient is non-progressing case of labor or is a case of obstructive labor, that will be counted as a score 2. Here very important in PPH also, if there is more than 1 liter transfusion, then definitely blood loss you need to consider for thromboprophylaxis. And very importantly, one more thing in your question, they do mention about stillbirth, but understand if it is a current stillbirth, then only it will be considered. Past stillbirth has no importance over here. So this is just for your knowledge to make you clear. Again, that annexure talks about thrombophilias. In that context, very hi- high risk, intermediate risk, and low risk of thrombophilia. So in that category, you need to understand that how we are proceeding for the thromboprophylaxis management in antenatal and postnatal. Please go through this chart very importantly. Let's come to the question. You have been asked to see a 37-year-old para 1 at 25 weeks of gestation, and she had an elective C-section for a breech presentation at 39 weeks in her first pregnancy. This is her second pregnancy, and she now describes a small painless lump in her right breast, which she has discovered accidentally. There is no history of bleeding per nipple. She's worried as she has strong family history of breast cancer, and you arrange an urgent referral to the specialist breast team. So, what is the most first appropriate first line imaging modalities over here? Wonderful. It's about ultrasound scan. Once you perform the ultrasound scan, most of the things will be very clear over here. In terms of cytology and biopsy, cytology during the course of pregnancy will be inconclusive, and that's the reason biopsy will be required. So ultrasound is used to assess the lump. Mammography is necessary after the cancer is confirmed to assess the extent of the disease into the contralateral breast too. And cytology is often inconclusive, as I mentioned, because there are the proliferative changes that could be seen. Let's moving ahead in the maternal medicine. There are a couple of infections you should be knowing well, because these are the patients which have very frequently been seen in obstetric OPD. Let's talk about herpes simplex virus, the recurrent genital herpes. In that context, you need to treat the episode with a standard dose of acyclovir if necessary. And then the acyclovir again start at 36 weeks of gestation till the time of delivery. And it is given with a dose of 400 milligram 3 times in a day. If it is a primary acquisition of genital herpes in the first or second trimester, then you need to treat the primary episode with a standard dose of acyclovir. And yes, the delivery will be offered by means of vaginal delivery. If it is a primary episodes and the lesions are, then definitely vaginal delivery is not a safer option. If at the time of delivery the genital HSV lesions are active, then yes, in that context, the normal postnatal care and the discharge home if the baby is well at 24 hours, and advise the parents regarding the latter management if there is any concern. If the primary acquisition of genital herpes happened in the third trimester, how to do with this? Then you have to treat the primary episodes, and you have to start with the standard dose of acyclovir. And you need to consider this acyclovir 400 milligram 3 times in a day till the time the delivery has been done. It is always recommended to perform a C-section, especially if you are expecting the delivery of the child within 6 weeks. If vaginal delivery is done, then you need to inform the radiologist so that on baby's condition, if the baby is well, then they can go ahead with a acyclovir 20 milligram per kg 3 times in a day for 10 days till the time you are awaiting for the result for the child. And if baby is unwell, then this lumbar puncture will be performed in order to confirm that baby has been already been affected. Inform your neonatologist for the normal postnatal care if the discharge is for home and if the baby is well at 24 hours. And again, always intimate the parents about the further course of treatment. Whenever it is a herpes simplex virus infection and there is a premature pre-labor rupture of membrane, that is, you are having this rupture before the onset of labor pain and before 37 weeks of pregnancy, that is considered as pre-labored premature rupture of membrane. So in that context, you need to do a MDT evaluation involving the obstetrician, neonatologist, and the gum physician. Gum is nothing but a genitourinary medicine physician. If the decision is made for the immediate delivery, then the benefit of C-section will always remain. If initial conservative management has been decided, then it is recommended for the IV acyclovir, which is 5 milligram per kg every 8 hourly. The prophylactic steroid should be considered. If the delivery is indicated within 6 weeks of primary infection, then yes, as I said, delivery by C-section. And again, you still offer some benefit despite of there is a prolonged rupture of membrane. But it is always better that child will be having less exposure by means of C-section as compared to the vaginal delivery. But if it is about a recurrent genital herpes, the risk of neonatal transplant is very small. It is like 1 to 3%, and it may be way by the morbidity and mortality associated with the premature delivery. And if it happens before 34, you can consider for the expectant management, which include the oral acyclovir 400 milligram 3 times in a day for mother, and antenatal corticosteroid treatment will be taken. After 34 week, you need to discuss the risk and benefit, and immediate delivery and expectant management will be considered. As I said, the risk of baby of having the neonatal herpes is low, which is 0 to 3% for the delivery in a recurrent genital herpes. Talking about having the combination of HIV and HSV, women who are HIV positive, as we know that in a normal patient, the suppletive course of a cycle will start at 36, here it starts at 32 weeks of gestation. That is a very important difference over here. In terms of neonatal herpes, couple of questions do been asked in exam. The neonatal herpes may be caused by HSV1 or HSV2. 50% neonatal herpes is because of 1 and 50% because of 2. And most of the cases of neonatal herpes occurs as a result of direct contact with infected maternal secretion. Although in 25% of the cases, a possible source of postnatal infection was identified, the postnatal infections may occur as a result of exposure to the orolabial herpes infection. Infant presenting with the symptoms localized to skin, eye, or mouth alone have a base prognosis and represent approximately 30% of the neonatal herpes infection. 70% of the infant with the neonatal herpes have a disseminated or CNS infection, and approximately 60% of the infant with the local CNS and or disseminated disease will present without skin, eye, and mouth infection. Understand these percentages, which is very important. Coming to the another version of herpes, it is nothing but a chickenpox. We know that the drugs are very same over here, but understand the doses in herpes is different, doses of acyclovir in chickenpox is different. Talking about varicella zoster virus is a DNA virus which is transmitted by respiratory droplets. Antenatal testing is not recommended in United Kingdom. Seronegative women identified in pregnancy should be offered a postpartum immunization. Women who are vaccinated postpartum can be reassured that it is safe to breastfeed the child. When contact occurs with the chickenpox or shingles, a careful history must be taken to confirm the significant chickenpox is infectious for 2 days before the appearance of that rash. Pregnant women with an uncertain or no previous history of chickenpox who have been exposed to the infection should have the blood test done in order to determine the varicella zoster immunity or non-immunity, and based on that you can proceed. So these are the couple of tests that can be performed. If pregnant woman is not immune to the varicella zoster virus, then she had a significant exposure, she should be offered immunoglobulin. Immunoglobulin is effective when it is given up to 10 days after a contact. In a case of continued exposure, this is defined as 10 days from the appearance of the rash in the index case. Non-immune pregnant woman who have been exposed to the chickenpox and now she has taken the immunoglobulin, then she has been considered as infectious for 8 to 28 days. But if she doesn't take immunoglobulin, then it is 8 to 21 days. Understand, it is if immunoglobulin is given, it is 8 to 28. If not given, then 8. If it is given, then it is 8 to 28 days. And if it is not given, then it is 8 to 21 days, which is considered as a period of infections. Second dose of varicella zoster hemoglobin may be required if further exposure is reported and 3 weeks has already been passed since the last dose. Acyclovir is administered here, the dose is different, 800 mg 5 times in a day for 7 days in an order to reduce the duration of fever and symptomology of varicella. Per se, the acyclovir is not licensed for use in pregnancy. If woman smokes cigarette and she has a lung disease or she is immunosuppressed, including those who take the systemic steroid for in preceding 3 months or in the second half of the pregnancy, the hospital assessment should be considered in the absence of any complication. Women who develops the chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after the infection for a discussion and detailed ultrasound examination. Amniocentesis should not be performed before the skin lesions have completely been healed. And amniocentesis has a strong negative predictive value but poor positive predictive value in detecting the fetal damage. If maternal infection occurs in the last 4 weeks of pregnancy and there is significant risk of varicella infection to the newborn, then the planned delivery normally should be avoided for at least 7 days, because in that 7 days, baby will get the antibodies from the mother, and that is the benefit for the child. Delivery while the chickenpox vesicles are active, it may be extremely hazardous and may precipitate the maternal hemorrhages and coagulopathy due to the thrombocytopenia or hepatitis. Supportive treatment and intravenous acyclovir are therefore desirable in allowing the resolution of rash, immune recovery, and transfer of protective antibodies from mother to fetus. However, delivery may be required to facilitate the assisted ventilation in cases where the varicella pneumonia is complicated by the respiratory failure. Women with chickenpox should breastfeed if they wish to and are well enough to do so far. If there are active chickenpox lesion, which is closer to the nipple, they should express the breast milk from the affected breast until the lesion has crusted over, and the expressed breast milk may feed to the baby who is receiving the treatment with varicella zoster immunoglobulin or acyclovir. So this is the flow chart which is mentioned in the guideline, which help you to understand when your patient takes the immunoglobulin, what need to be done, when it is not given, and what it should be done. Please go through this flowcharts. These are very important flowcharts which gives a very important answers for important questions. Let's talk about SLE, systemic lupus erythematosus. So very important medical condition. In medical school in autumn and quantum, we have already studied much more. Let's understand the obstetric side of SLE. It is an idiopathic autoimmune condition which has a multi-organ involvement. If you see as the male to female ratio, female to as to male ratio, it is 9:1, which means that female are at more risk. Clinical features include the systemic connective tissue disease, which is characterized by most of the uh, period of disease activity and remission. That is, activity period is called as flare-up. 6% of the patient have other autoimmune conditions too. Joint involvement is the most common clinical feature seen in 90% cases, that is called as arthritis. Skin involvement is seen in near about 80% of the patient. Genetic predisposition and environmental triggers such as ultraviolet lights and the viral infections can trigger this condition. 25% cordons for the SLE among the monozygotic twins will be seen. So what are the investigations that we can done for this patient? Let's talk about the full blood count. It may show the normochromic normocytic anemia, neutropenia, and thrombocytopenia. Whenever there is increased ESR, normal C-reactive protein, and low complement level of C3 and C4, it indicates that it is an active condition. The most common antibody, which includes the anti-nuclear antibody, which is seen in near about 96% of the patient, and the most specific is double stranded DNA, which is found in near about 78% of the patient. Talking about anti-Rho and anti-La, the anti-Rho and anti-La is present in about near about 30% of the patient, and the La antibody is seen in near about 40% of the patient. This SLE talk article is with n number of percentages. Please try to remember this percentage up to the level you can. What is the effect of SLE on pregnancy? We know very well in internal medicine, we have already studied about that what impact it has on normal body system. The pregnancy and particularly the puerperum, there is increased risk of likelihood of flare near about 40 to 60%. The lupus flare more likely if the disease has been active in the last 6 months, and that's the reason in medical condition most of the time the 6 month remission period is very mandatory before they embark on the path of pregnancy. Less common in women who continue the maintenance of hydroxychloroquine, which is considered as one of the pregnancy safe drug. The risk of renal flare is near about 30%. And whenever there is a renal flare in the past or lupus nephritis in the last couple of 6 months, then definitely in that context, pregnancy will not be recommended. Women should be advised to delay the pregnancy until at least 6 months after the lupus nephritis flare. What is the effect on pregnancy? The risk of spontaneous miscarriages, fetal death, preeclampsia, preterm delivery, and fetal growth restriction will be there. Talking about lupus nephritis has increased risk of fetal loss, the preeclampsia, near about in 25 to 30% of the cases, and the fetal growth restriction is 1 in 4, that's near about 25%, particularly if the hypertension or proteinuria is existing. So what is the management from obstetric point of view? Medical condition, definitely it requires a multidisciplinary team approach, 4 weekly visits More often, if the disease is very active, for those women who are having anti-Rho, anti-La positive, then yes, fetal heart rate should be monitored because this is the one of the leading cause for having a congenital heart block. And for that purpose, the fetal echo is assessment at 18 to 20 weeks, and 28 weeks will be required. The risk of thromboembolism need to be discussed and managed. Whenever there is a flare, there is an increase with whenever the disease is active between initial before 6 months of the conceptions. Medical management and the adjustment of drug therapy will be required. The fetal management includes that there is a scanning of at least 4 weeks to screen for the fetal growth restriction. As I said about the echo, it has to be done at 18 to 20 weeks, and at 28 weeks, uterine Doppler should be carried out at 20 weeks, and it should be repeated 4 weeks later if there is any abnormalities found. Very important thing that you need to differentiate between SLE and preeclampsia. So feature of lupus nephritis include the hypertension and proteinuria with or without hematuria. In addition, the lupus disease activity in non-renal organ system suggests that a lupus nephritis flare is more likely. The only definitive and reliable investigation that can differentiate between the preeclampsia versus lupus nephritis is renal biopsy. But generally, it is not taken during the pregnancy. But if it is required, it has been taken in the first and second trimester. If that result is going to change your management, otherwise, it is not required. Failure to respond to the increased dose of steroid or azathioprine, the other immunosuppressive drugs can be considered, for example, mycophenolate and tacrolimus. Per se, the phenolate, mycophenolate mofetil is considered as one of the drug which is not to be continued during the pregnancy. We know that tacrolimus is something where we need to think about the monitoring of the drug. This is the example pictorial diagram of lupus neonatal syndrome. Talking about neonatal lupus syndrome, it is passively acquired autoimmunity. Very importantly, you should know that the cutaneous lesions are the most common manifestation, and congenital heart block is something which is very serious. 90% of the mother are affected with the offspring having anti-Rho antibodies. 50 to 70% have anti-La antibodies, and the prevalence of anti-Rho in general population is less than 1%. Although the anti-Rho or La antibody are present in near about 30% of the patient with the SLE. In baby with Rho or La positive mothers have the risk of transient cutaneous lupus is about 5%, and congenital heart block risk is about 2%. If the previous child has been affected, then there is a 16 to 18% with one child affected, and 50% if the two child are affected, that is the recurrence. So moving ahead, talking about congenital heart block, it appears in utero and is permanent and may be very fatal. It is detected at around 18 to 20 weeks. You can see that there is a fetal bradycardia, and pathogenesis is nothing but the inflammation and fibrosis of the conducting system, that is the pacemaker system of our heart, that include the SA node and AV node. Maternal antibody profiling has revealed that the development of the congenital heart block is strongly dependent upon the specific antibody profile, which is the anti-Rho. It is likely that the heart block progresses first, starting from the first degree, second degree, and then it turn up into a third degree. Neither steroid or nor the IV immunoglobulin can reverse the heart block once it has been established. Salbutamol is given to the mother. It may be beneficial to the fetus if there is any bradycardia and that causing the fetal heart failure. Perinatal mortality is near about 20% if the affected children is dying in the early neonatal period. Most infants who survive this period do well, although 50 to 60% requires a pacemaker in early infancy. Talking about one more very important condition, that is APLA. We see that many of the patients coming with a recurrent miscarriages, they do diagnose with a case of APLA syndrome. So what is the diagnostic criteria? Diagnostic criteria, it is nothing but a Sydney criteria, and it has the vascular thrombosis event. It includes the pregnancy morbidity and it includes the lab findings. So it is clinical versus lab. Let's discuss about lab. First of all, in lab parameter, at least two investigations to be done at 12 weeks apart, which include the lupus anticoagulant, anticardiolipin in medium to high titer, and beta 2 glycoprotein. If it is about vascular thrombosis, at least one episode of confirmed arterial, venous, and small vessel thrombosis in any organ or tissue system. Pregnancy morbidity, which include at least 3 unexplained consecutive pregnancy losses less than 10 weeks of gestation. At least one unexplained loss of normal fetus more than 10 weeks of gestation. At least one preterm birth of normal neonate at less than 34 weeks of gestation due to the eclampsia and severe preeclampsia. So these are the clinical features of Abla syndrome. Now there are certain clinical questions. In this clinical question, we have getting the answers from the chart which is mentioned in the TOG article. So let's go with the chart. You can pause the video and come back to the question for your answers. If Antiphospholipid syndrome with a prior fetal death or recurrent pregnancy loss is present, in that context, it is recommended that use the aspirin and low molecular weight heparin. If the syndrome is with a prior venous or arterial thrombosis, then there is a low molecular weight heparin at intermediate or therapeutic dose will be required. If antiphospholipid antibodies without clinical features but having healthy previous pregnancy, no treatment is required. Only low dose aspirin is sufficient. And primary gravida with isolated APLA or APS with recurrent thrombotic event, in that context, the low dose of aspirin and fetal monitoring and full therapeutic dose of low molecular weight heparin will be required over here. Coming to a EMQ pattern questions. This EMP pattern questions is about the hypertension guidelines. That is the NICE guidelines. So let's go with the question. Primary gravida at 35 weeks, present with the blood pressure of 140/95 and urine dipstick shows that trace. Second is about pregnant woman at 36 weeks, which is admitted with a blood pressure of 160 millimeters, 160 to 110 millimeter of mercury, and the urine dipstick trace, and the continuous and severe headache is there. Somewhere putting into the severe preeclampsia. Going ahead with the primary gravida at 35 weeks presents with the blood pressure of 160/110 with a proteinuria 1 plus. So what will be your answers? These are the answers that will be helpful for you to know more about it. So going ahead with the chart, the management of pregnancy with gestational hypertension. Understand that in the guideline, it is mentioned about gestational hypertension, it is mentioned about preeclampsia, and it is mentioned about the chronic hypertension too. So let's talk about gestational hypertension here. It is about whenever the hypertension diagnosed first time during the course of pregnancy, it is called as gestational hypertension. Whenever it is before 20 weeks and even if it is continued after the delivery, then that will be considered as a chronic hypertension. And whenever it is after 20 weeks but along with the proteinuria, and this, that will be always considered as a preeclampsia case. So considering this basic definition into the mind, first of all, make a diagnosis of your case, whether it is a chronic hypertension, whether it is a gestational hypertension, or whether it is a preeclampsia. These all three are coming under the quantum of pregnancy-induced hypertension. So the grading of hypertension will be like a mild, moderate, and severe category. Severe will be always 160/110 millimeters of mercury and above. So whenever it is mild to moderate, do not routinely admit the patient in cases of gestational hypertension, but in preeclampsia you need to. In severe high gestational hypertension, definitely you need to admit, you need to control the blood pressure. Whenever the BP is above 140/90, then definitely antihypertensive will be required. The target level of blood pressure will be always 135/85 millimeters of mercury. How to do a monitoring? Once or twice in a week if it is mild to moderate, every 15 to 30 minutes in a case of severe. Dipstick urine protein testing, because you need to confirm whether is patient turning into a preeclampsia or not. So it is once or twice a week, and it is done on daily basis when it is admitted to the hospital in cases of severe gestational hypertension. Talking about blood tests, the full blood count, the liver functions and the renal functions at presentation, and then weekly is required. The PIGF, that is pregnancy induced growth factor testing, is required on one occasion if there is a suspicion of preeclampsia. Now, how are we going to manage the pregnancy with preeclampsia? Previously, we discussed about now gestational hypertension. Now here it is preeclampsia. As I said, in preeclampsia, even if it is a mild moderate, you need to admit if any clinical concern for well-being of the woman or baby, or if high risk of adverse events suggested by means of full pipers or PrEP score. These are the scoring system that you should be knowing about. Talking about the further management, like blood pressure measurement, if it is mild to moderate, at least for every 48 hours, and in severe you need to monitor till every 15 to 30 minutes till the BP settles down, at least 4 times daily while the woman is an inpatient. Dipstick urine monitoring only repeat if it is clinically indicated. Talking about blood tests, it is done twice a week, and if it is a mild to moderate, and in severe it is done 3 times in a week. These are the questions. Please go through your answers very quickly. If any queries, please drop your queries into the chat box. Let's talk about the recurrence of PIH, that is pregnancy-induced hypertension. In the guideline, it is mentioned about the recurrence of PIH, where a very important question, that is a remarkable question, which is a contradictory to the previous version of the guideline that is coming ahead. So before that, just understand this fetal assessment in a mild, moderate, and in a severe category. If it is a mild, moderate category, then ultrasound assessment of the fetus at diagnosis, and if normal, then we need to repeat after 2 to 4 weeks. If clinically indicated for woman with report says that there is change in the fetal movement, vaginal bleeding, abdominal pain, or deterioration of the maternal condition. But in severe category, if it is normal, then it has to be reported every 2 weekly basis. Talking about further course of discussion about the incidences. In this incidences, here I was about to mention that if the birth is done at 28 to 34 weeks, approximately 33% of the patient will have the preeclampsia in the next pregnancy. Previous version of the guideline was talking about 25%, but now this version talks about 33%. You might see this question into many of the older version of the textbook where the answer says about 25. Understand, it's very important to know that, because whenever you see this patient in your OPD, you need to talk about the recurrence in the upcoming pregnancy. So if birth happens between 28 to 34 weeks, then it is approximately near about 33%. And if it happens between 34 to 37, it is near about 23%. So this is very important question for you. And a numericals about risk of congenital heart block in SLE is 2 to 3%. Recurrence of congenital heart block is near about 16%. Risk of PRM in SLE is near about 20%. And talking about apply antibody in SLE is near about 30%. Here we come to the end of this session, and the quick revision. These are the very highlighted topics for your MRCOG Part 2 exams. A little progress in each day adds up to the bigger results. We are very coming closer to the exams. Hope this session will be helpful for you. Wishing you all the best with lots of love and good luck. I'm Dr. Dinesh, one of the mentor of Team StudyMEDICS.